So we're here talking about a method, or using a method to speak about subcomponents of it. We're talking about the concepts, as we have previously, of lever, wedge, and screw, of implicit learning, explicit learning, palpation, patient positioning. So first of all, the reason that I have the patient on his side and I'm on this side, where usually if I was going to work on something on the posterior surface of the patient, when they're in lateral, I would be behind them and they would be closer to this edge. And we talked about that in our patient positioning series that we did quite a while ago. But right now, what I want to do for the purpose of the camera, so there's enough angle, I'm going to work in and around the scapula, but I want to do so that it's visible, so the patient is on his side facing me. There will be times when you will work from the front of the patient to work on the back, on their posterior surface when they're in lateral. But the challenge there being, again, when we refer to our patient positioning concepts, that I cannot see what I'm doing. So preferably you want the anatomy exposed, free move in the plane required, and preferably visible. So right now, I can't really appropriately see his scapula or the medial border. If I do this, I might be able to see it, but then I'm leaning and also my hamstrings will start to hurt. So that's the number one challenge with what I'm going to do, but the reason I'm doing it is so that it's visible. So if I want to work on the medial border or any of the borders of the scapula, I can, in essentially a short lever sense, I can just wrap my hands around the scapula and I can glide it, right? So you see there's a glide. There's a certain amount of motion of the scapula. Here I can palpate the full medial border or the majority of the full medial border by wrapping around it. Sometimes in some patients you won't be able to find it initially, so what you can do is simply push it back. You can wing the scapula or push the scapula off of the wall. So some insight into how to do that in a way that essentially ends up being smooth, right? So when we talk about relational motion, one thing moves in relation to the other. Because the patient is on his side and the table makes stable, less table means I need to make the patient stable. So when we put him on his side, as I move him, his pelvis is relatively stable because his knees are bent, his hips are bent. So as I push back, I may not actually wing the scapula. So what I want to do to be able to identify the medial border is stabilize the thorax and move the scapula. So as my forearm comes around, I can just block. There we go. I stabilize the thorax to some degree. I can push back in and around the shoulder, so in and around the GH joint, in and around the AC joint, and push back, the scapula will wing somewhat. I can identify the medial border. We're talking about palpation, get as much as you can touch, broad contact for multi-point discrimination, those concepts. So here I can find the full medial border, and then I can slide into a position where the yoke of my hand is in and around the inferior angle, right? And I can glide. So a relative short lever approach. And I can work in here, work around the scapula. So I can identify it by stabilizing, moving in a relative short lever fashion. I can find that medial border of the scapula, I can work around it. Once I have this, so the concept of moving from the known to the unknown, once I have the medial border, I can move around the scapula and start to identify other soft tissues, so muscles of the rotator cuff and whatnot. But first, we're just generally talking about a short lever approach, right? So I'm going to have one hand in and around the AC joint, in and around the GH joint, very generally speaking, in and around the clavicle, because all of these structures connect in a very close area. And if I'm broadly in there, so if I think about that concept of broad contact for multi-point discrimination, and contact equals control and control equals safety, I can just broadly go into the area of the top of the shoulder, and I've got all those structures in most patients based on the size of my hand. Most patients' shoulders are not going to be so big that my hand can't cover all of those structures. Then I identify the medial border, and I've got the majority of the scapula, so I can identify it. And then the concept of relational motion, if I want to move the scapula, the rest of the patient has to stay relatively still. So when he's on his side, this is exposed, free to move in the plane required. In this case, it's not visible as we talked about earlier, but I can do most of what I want. If I come to a relatively longer lever approach, I can use the humerus as the handle and the lever to start to glide the scapula, right? Now in this case, because I'm going to use the humerus, I'm going to have to use my up-table hand. So instead of using the shoulder itself, or the clavicle, or the AC joint as the lever, right, or the scapula itself as the lever with my other hand, what I've done is I've created a situation where my handle is, in this case, the elbow. So the long lever, I'm holding the handle of the elbow and I'm gliding. So now I have to use this hand, and again, broad contact for multi-point discrimination, get as much as you can touch, move from the known to the unknown, concepts of palpation. You can look back at those videos should you be interested. I can identify what I'm looking for, and I can start to work around. Now the challenge here is that I actually lose some capacity. If my hand's here, if my forearm is coming straight around, I lose some capacity to manipulate that clavicle, or sort of the shoulder blade, scapula, as I desire. So now I have to use that lever and really move that arm around in relation to how I want to test, how I want to move. Now, something to keep in mind, contact is control and control is safety. Now, if I'm here, my forearm's coming around in this case, and this is an opportunity to speak about explicit learning again. So explicitly, right, I'm doing this and it's not moving the way I want. I can't control this or feel what I want to feel. Now, if I use the concept of contact as control and I wrap around here, right, so I use the long lever of the humerus and I use the relatively shorter lever in around the AC joint of the clavicle, the scapula itself, I wrap around here. Now, using both of those ends for leverage, I can control the scapula itself more the way I want to. So explicitly, this isn't working the way I want it to. Come around here, adjust my hold, and I can do more of what I want. That being said, it isn't as ideal because, as you can see, the patient's rocking around. So I have a challenge. I'm not controlling the patient's torso as much as I'd like. So now what I'm going to do explicitly, just to show this, I'm going to see what happens if I straighten out the patient's arm. So now the lever includes the forearm, right? I'm further away, I have to do more work. So lever and the load and the effort are a little farther from each other, and I can start to move. The reason I would prefer to be behind the patient at this point is because I could control everything better. Now to wing the scapula, right, to put it into positions that I want it in, with my forearm just wrapping around and me reaching towards the medial border, I'm able to do that better. So I lengthen the lever and I can control the scapula more the way I want without wrapping around here, right? Now this, when I wrap around the clavicle, when I wrap around the top of the shoulder, gets a little clunky with this lever. So in this case, what I've learned explicitly, right, I've tried two different things, is that I can do more of what I want when I hold the patient's arm like this. So the small adjustment I made without even knowing that I made it and pausing to reflect, I brought his arm onto my abdomen, so now I can use my full body to move. Right? So contact is control and control is safety, broad contact. Again, that keeps coming into play. The concepts of explicit learning. Right? So when I shorten the lever and I work here, having my top hand in this position doesn't work as well, it's a little clunky. This works better, I can get more of what I want. Right? I support the patient more, I can control him better. When I lengthen the lever to include the full arm, I pull him to my abdomen, and I've learned this on the fly. I haven't thought about that before. Right? But that's the concept of explicit learning, which relies on implicit learning. It relies on longer term learning, longer term kind of databases and information. Right? But the lever is the arm. The thing that I'm working on dominantly is the medial border of the scapula. Right? So we can have relative short lever approach, kind of a medium long lever or a long lever approach, but I have to adjust my hold to get the control that I want, as we've talked about, or a longer lever approach. The reason that we want to demonstrate this and talk through it is to highlight some understanding, again, of how these concepts begin to sew together in what could be a fairly straightforward method. So all of these things are happening at all times, all of these different concepts are always at play. Initially, it's of use to break them apart, explain them, show what they look like in real time, take the time to explain them such that when you start to master the subcomponents or have a greater understanding of the subcomponents and the subconcepts, when they are all sewing together for you, you can then understand the method better. And then things become a little bit more automated. So you get into that longer term learning. You have more available schemes or knowledge schemas or retrieval schemas you start to do that over time. But to break them out so that you can discuss them, so that you can see them, so you can identify them, may be helpful. And understanding that one of the reasons we use video, or we're trying to use video, is so that it's not just a lot of words, you can actually see the process. So sometimes turning the volume down and looking at it, and just seeing my hands move around on the patient's body or whatever, you may be able to pick it up better. So you have multiple ways to access the information that's being delivered, not just auditory, not just my voice, not just the visual. You can join those together, and then you can remove one of them. You can kind of take the audio away if you want. So hopefully that helps understand some of the concepts again. You know, what's going on with the lever, what's going on when the method isn't working the way that I want. Can I make adjustments? Do I understand how to make adjustments in my hand placement, my forearm placement? Am I using the concept of contact as control, broad contact for multi-point discrimination? Have I positioned the patient in a reasonable way? Am I using relational motion to my advantage? Things like that. To think about that in real time is very cumbersome. It's not useful. But to understand them before you go into something, to try to work with each of those concepts as a guiding light, and then over time, as those kind of drop into your learning, your motor learning, your learning schema, you put them together and they automate, they become more automatic. And your technical application, your capacity to interface with the patient in a positive way will improve over time.